Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Breast Cancer Update and Q&A with Dr. Parvin Peddi. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. And thank you to Sharsheret for allowing us to partner with them for their summit this year. Elena?
Thanks, Rebecca. I'm excited to be here and to be partnering on today's event program. I'm the California Outreach Coordinator for Sharsheret, which is a national nonprofit that supports individuals and families impacted by breast and ovarian cancer, as well as those that are at an elevated genetic risk. While our expertise is in issues impacting the Jewish community, we serve everyone regardless of faith. All of our services are free and conducted virtually, so they can be accessed from anywhere in the country. We provide support for caregivers, people deciding if they should seek genetic testing, those going through treatment, and anyone post-treatment. Our team of social workers are here to provide emotional support and connect to various resources, including financial assistance for non-medical needs like real hair wigs, our busy boxes for women going through treatment who have young children at home, peer support when appropriate, and more. If you're interested in more information, please feel free to check out our website or our social media accounts, or feel free to be in touch with me directly. I'll put my contact information in the chat.
Thank you. And without further ado, I'd like to introduce our workshop speaker. Dr. Parvin Peddi is the Director of Breast Medical Oncology at Margie Petersen Breast Center in Santa Monica. She's a dedicated breast oncologist and Director of Breast Clinical Trial Program at St. John's. Thank you so much for being here with us today.
Thank you very much for having me. And thank you for everybody who is here. And thank you, Elena, for including your organization as well. It's Breast Cancer Awareness Month, so this is timely. And I have this talk as, kind of like a generalized overview of breast cancer in terms of diagnosis as well as treatments, but I want to leave a lot of time for questions because I feel like that's when people really ask what's on their mind, and it's can be easier to focus in and kind of go point by point because there's so much to cover in breast cancer. So I work at St. John's, which is in Santa Monica, and I have been in the South Bay before as well, hence my connection to the South Bay cancer support community. A lot of my patients still come from the South Bay, and it's a great organization. So thank you so much for all that you do at Cancer Support Community. A lot of my patients use it, and it's great. So anyway, without further ado, I will talk about breast cancer a little bit in general, and I'll start with mammogram, what mammogram looks like when somebody is diagnosed. So we start with diagnosis, and then we'll go over, then what happens after someone actually gets a diagnosis of breast cancer, and how does a medical oncologist such as me figure out how to treat them. So when the radiologist says the CMS on mammogram, this is a representation of what it looks like. This is a mammogram from one of my patients, and you see this thing that is here. It's kind of hard, like people are like, oh, what is all this other stuff? So glands, in the breast kind of show up as white too, but shouldn't have like this thickened mass-like appearance. So this is most likely breast cancer when they see this. And in this particular patient, it was proven as being breast cancer. And so usually when you see something on mammogram, you also look at it with ultrasounds. This is what ultrasound then look like in this patient. You see this round thing that is the breast cancer. And the reason you want to see it with ultrasound as well as mammogram is that biopsy is just easier with ultrasound. You can see exactly where you're going with a needle. You don't have to go through this big machine to get the biopsy done. But sometimes you don't find it on ultrasound. It's something that you can only see on mammogram. then those patients have to get what's called a stereotactic biopsy, which is a biopsy with the guidance of the mammogram machine. So it's just a little bit harder technically, and probably not as comfortable for most patients, and could be a little bit more painful sometimes when they do it with mammogram. So that's why, you know, you do the ultrasound, try to find it that way, and try to do biopsy this way. And then a lot of patients also need MRIs, whether it's for screening and or at the time of diagnosis. Not for everyone, but a good portion of people. So the younger someone is, the harder it is to read their mammogram because their breast tissue is so glandular and it's hard to see things. So MRI could be better to evaluate the extent of disease in that patient before surgery. And then lobular cancer subtype. A lot of times these lobular ones, and I'll talk to you a little bit later, are very infiltrative, like sort of like finger-like projections. And because they're not this big ball of mass, it's harder to see them on mammogram. So MRI could be better for these patients too. So yeah, so everybody who gets diagnosed with breast cancer would get a mammogram, obviously, almost always an ultrasound, and a lot of times an MRI as well. And just so you know what an MRI would look like, so this is a different patient, a much bigger cancer that has a mass in their breast, and that's what this is. I mean, there are lots of things that are much more subtle. This person is probably multifocal, and all this other stuff may be cancerous too. And you can see in comparison, obviously the other breast is very quiet, and these are just the blood vessels. Yeah, and as you go through the MRI machine, both breasts are imaged at the same time. So you always get a good picture of if anything is going on in the other breast that you didn't know about. So yeah, so then you've done all of these, you do a biopsy, then you also figure out if someone needs genetic testing at the time of diagnosis. Most cancers, breast cancers, are not genetic. That surprises a lot of people that come to my office, first time diagnosed. They're like, nobody in my family has it. How come I got it? And I have to explain that only a minority, like 5-10%, give or take, of breast cancers are genetic. Like we find a gene, it's hereditary, and that's why they got it. Majority of breast cancers, we don't have a gene that caused it. It could be environmental. It could just be with age. As we get older, mistakes with the passage of time can happen. But when we do find a gene, is, you know, you may have heard about the BRCA genes, BRCA1 and 2, they're two different genes. And there are many other ones too, most notably this thing called PALB2. But these days, when a person gets genetic screening, it's like lots of genes. It's not just a BRCA, it's usually 10 plus at least. They get a comprehensive genetic screening, so that even the lesser known genes we screen for to see if they have it or not. And then who should get genetic testing? Like, you know, you get diagnosed with cancer, should you get genetic testing? Not everybody. So if somebody's in their 70s, not a whole lot of family history, you're not going to find a gene. But if someone is young, they have breast cancer in both breasts, male breast cancer, and there are several other ones that I have listed here, that these patients do need genetic screening. And this last one, metastatic breast cancer, is not because it's more common to find genetic mutations in people who have metastatic cancer, but the reason you tested for all of them is because there is a specific drug that is approved for the treatment of people who have stage 4 breast cancer that have this BRCA gene. So yes, it's still 5-10% of them, but you want to know about all of them, so you don't want to miss anyone. So that's why it's approved for anybody who has metastatic breast cancer should get tested for the BRCA genes, in case it would qualify them to get this drug as part of their treatment. So now when someone is diagnosed, the next thing they want to know is what's their stage. So stage 1 is just in the breast. Stage 2 could be a little bit bigger, or it could be a lymph node. Stage 3, definitely on the bigger side and definitely involving lymph nodes. And stage 4 is when it's outside of the breast. And that could be anywhere. Could be lungs, bone, liver, brain. Those would be the top places that it could go to. And the types of breast cancer. So you have, as I mentioned earlier, lobular, versus the most common one, which is ductal breast cancer. So basically, breast tissue is made of ducts and lobules. So breast cancer can, you know, start in either one. So lobules is where the milk is made and goes through the ducts to go throughout the nipple. About 90% of breast cancers are ductal. They start in the ducts of the breast. But a minority of them, about 10%, are lobular. And for the most part, we treat them about the same. It's more like what drives their growth, are they hormone positive or not? So it doesn't make a difference as much in terms of treatment, but in terms of at the diagnosis stage, it does. So people who have lobular cancer, usually we recommend to have an MRI because the extent of disease sometimes is underestimated with a mammogram. So that is the main difference between the two. And on average, you can say, you know, this one is more aggressive versus not, but in a particular person, doesn't matter if it's ductal or lobular. You need to know more specifically about the cancer. What does it like for growing? How aggressive is it? So, and when I say what type of breast cancer, then it brings us to receptor status. So there are 3 receptors that we check in every breast cancer. Every pathology lab is going to be doing this. Estrogen, progesterone, and HER2. So estrogen and progesterone kind of go hand in hand. They're basically hormonally driven breast cancers. And those cancers are usually slower growing because normal breast tissue likes estrogen. So the cancers that also like these are more like normal. So they are less aggressive, slower growing, and they have drugs against these receptors. And then this third thing called HER2. So I have an example here of like what a normal breast cancer, I guess normal, like a regular breast cancer looks like, or normal breast tissue, has some copies of this protein called HER2 on its cell surface. This is the gene, and then the protein itself is on the surface. But the patients, when we say they have HER2 positive, that means they have too much. Another term for it is HER2 amplified. So they have millions copies of this HER2 on their surface. Why does that matter? Because this thing can drive the growth of these cancer cells. So these cancers have this additional thing to help them grow, this HER2 thing, and they're more aggressive if not treated properly. If they're treated properly with anti-HER2 drugs, actually they do better than other types of breast cancer a lot of times. But so then it's crucial for the patient and their doctors to know that. And there are 2 ways of measuring HER2. I mean, that could take all day just talk about that, but you have to make sure that your doctor is really positive that you don't have HER2 and it's been tested both ways, because it would really change the management if it were to be HER2 positive. Now, in terms of goals of therapy, and hold your thoughts or any questions, we'll get to them soon. I'm not going to talk too long in terms of the didactic of this, just want to cover the basics for a discussion. In terms of goals of therapy, if someone has stage 1 to 3, so meaning it's confined in the breast and or the lymph nodes, the goal is still cure. Even if it's in the lymph nodes, the goal is cure, whether it's chemo, surgery, anti-hormonal therapy, the goal is cure. And for the majority of patients, you can achieve that, to never ever have cancer come back. If it's stage 4, metastatic, meaning it's outside of that area, breast or lymph node, unfortunately, we cannot cure these patients, at least with the science we have right now, but we can prolong life, and we can reduce symptoms, and we can actually shrink things for a long time, depending on the type of the breast cancer. And the science is always improving, so the amount of time we're able to do that has progressively gotten longer and longer. And I'm sure it will continue to do so. But the goals are a little bit different. So we're not going to try to completely cure it, but more like trying to at least control it. And in terms of treatment, so it really depends what type of breast cancer you're talking about. Is it the hormone receptor positive, meaning drives growth from estrogen and hormones? Is it HER2 positive? Those cancers that I said have millions of copies of that protein. Or is it triple negative, meaning doesn't have estrogen, progesterone, or HER2? So briefly, I'll touch base about each one of them. So first, about the hormone receptor positive ones. So a patient has this, it's just in the breast and on the lymph node. Usually the first treatment you do is surgery. Okay, first you do surgery, take that thing out. If you can do a lumpectomy, do a lumpectomy. And then afterwards, still, you need to have something that goes throughout your body. Because when someone has cancer, has invasive cancer, that means microscopically it has broken through the duct wall or the lobule wall. And therefore, even if the lymph nodes were negative at the time of surgery, there's a good chance that the cells could have been could have spread through some other lymph node, through the bloodstream. And if you leave it as surgery or radiation, unfortunately, cancer can come back and somewhere else, metastatic and incurable at that point. So everybody, no matter how small the cancer, unless their body can't take the treatment, is recommended to do something. So people who have hormone receptor positive breast cancer, that is, I have here just a lymph node thing, that is at the very least anti-hormonal therapy. And we can go over that more so in the question and answer if there are questions, but there are lots of different pills for that, and there are injections for premenopausal women. So there are lots of different ways you can go against the hormones, but that's the bedrock of it. Like patients who have hormone receptor positive breast cancer, that's the thing that is targeted, the least toxic, that can go throughout their body to try to kill these cancer cells. And they need to be on these treatments for at least 5 years, sometimes longer. But some of these patients also need chemotherapy. So who needs chemotherapy as well? So they have hormone receptor positive breast cancer, they're going to get anti-hormonal, but some of these patients also need chemotherapy. So who needs that? There's a test called Oncotype that a lot of times we send to try to figure that out. So what that test is, in case you've heard it thrown around, is that it's genetic profiling of the cancer, and specifically 16 genes that are involved in the cancer being more aggressive, cancer wanting to get out of the breast. And this particular company basically tests expression of these and weighs the ones that are more important, more versus not, and puts in this complicated formula that spits out a number on the other end. And the lower the number, the lower risk of cancer wanting to come back, and the less chance or no benefit at all from chemotherapy. So this test can be sent for a lot of the lower risk patients to say, yeah, you actually don't need chemo. You're fine, just anti-hormonal, and that is it. So, so the test, numbers are: if the postmenopausal woman has a score of less than 25, they don't need chemo. If the patient is premenopausal, then there's some caveats between the scores of 18 to 25 that they need to discuss with their doctor to try to figure out if it makes sense for them to do chemo still or not. Because the premenopausal women have much more hormones on board. So seems like, maybe just the pill version of the hormones may not be able to do it completely for them. And some of them still need chemo. And so in addition to chemo, sometimes we add other drugs to the anti-hormonal therapy too. So there's a class of drugs called CDK4/6 inhibitors, and there's a drug in that category called Verzenio that is approved in combination with anti-hormonal therapy in higher risk patients. So these are people who have like 4 or more lymph node positive or really big cancer, but that's 1 to 3 lymph nodes. There are specific criteria. But that medicine combined with anti-hormonal therapy can improve their cure rate. So that's one medicine. And then another medicine is going to pause because of the plane just going by. I didn't know you could hear me. So another medicine that can help is a class of drugs called bisphosphonates that are people with osteoporosis take to strengthen their bones. But these medicines can also help prevent cancer going to the bone in high-risk cancer patients. So cancer was just in the breast, but it was in several lymph nodes, or they were high risk. And you can do this medicine as a prevention, so the cancer doesn't go to the bone. So those are additional things that some of these patients get. So here, then how about HER2 positive breast cancer? So briefly on that. One main part is that usually you do treatment before surgery. So patients always, a lot of times, if they haven't had breast cancer or know someone with breast cancer, think that, oh, I have breast cancer, I need to see a surgeon, I need to get this out first. But depending on the type of breast cancer, so if it's HER2 positive, you actually want to get your treatment, your chemotherapy before surgery. Why is that? Number one, the chemo works really well and is going to make the cancer easier to take out at the time of surgery. And number two, perhaps more importantly, you can see how well they responded to chemo, and after surgery, fine-tune your treatment afterwards. So if you gave them the chemo and the cancer went all the way away, that you did surgery and there was nothing left. You couldn't find a single live cancer cell. Wonderful. No more chemo afterwards. You did your part, is done. But let's say you did the chemo and you did a good chemo and you went for surgery and there was still some cancer left. There is a specific drug called Kadcyla, and I'll go over that in a minute, that has been now approved for that indication for those patients. But if you already did your surgery, you have no idea if the cancer that you had could have benefited from this additional chemotherapy. So critical for these patients to see a medical oncologist as well at the beginning. Then you do the surgery after chemotherapy, and you consider Kadcyla, that smart chemo drug afterwards, versus just Herceptin, which is an anti-HER2 antibody after surgery that doesn't have side effects really, and people do great on it. There's no hair loss, nothing. And every 3 weeks they come and get that medication. So what is Kadcyla? It's a thing that we had been trying to find for a long time, a so-called smart chemo, meaning a chemo that is targeted. So basically, it's this big molecule here is trastuzumab, the name for it, Herceptin, which is an antibody against HER2. So it's not chemo, it just finds the HER2 on the surface. But then we attached some chemo to it, some chemo molecules to it, multiple of them. This drug called DM1 that is so toxic if you just give it, not target it, that people cannot tolerate it. But you couple it just with this, and then when the whole thing goes inside the body, it finds the HER2. So this thing is the HER2. Then, when it binds to it, the cell brings it inside in these little capsules, and only when it gets inside, the chemo is cleaved off and gets released inside and kills just that cell, which is exactly what you want. You want the chemo to find just the cancer cells, not kill everything that is alive and dividing. So this drug was our first chemotherapy, like smart chemotherapy, that was approved for breast cancer and approved in 2019, and is critical that these patients then get their chemo before surgery, so they have access to this as a result. And we has cut the rates of breast cancer recurrence in half when used in this setting. If a cancer is metastatic and is HER2 positive, we actually now have a second smart drug called Enhertu, similar mechanism, the chemo coupled to the antibody to find the cancer cells. And this was approved in 2019 for HER2 positive breast cancer patients who are metastatic. And just last year was also approved for HER2 low. So that's a new category of breast cancer. Patients who don't have tons and tons of HER2, but have a little bit, and have enough that this drug is so good, it still finds them and goes inside and kills those cancer cells. So that's about 40% of breast cancers. So it's now approved in the stage 4 metastatic setting in those patients, and we're trying to see if we can use it earlier in people whose cancer has not spread, but maybe it's better than the other drugs that we have against HER2. So ongoing clinical trials are trying to figure that out. Does it beat Kadcyla, this Enhertu thing? And also trying to figure out, like in the after surgery, whether we can use it or not. So lastly, I'm going to talk about triple negative breast cancer, and pretty soon I'm going to open it up to questions. So triple negative breast cancer means you don't have estrogen receptor, you don't have the HER2 receptor, so really don't have a whole lot of targets. So these patients unfortunately need chemotherapy, but more recently we have at least identified some of them who could get immunotherapy in addition to chemotherapy. And a lot of times in these patients too, just like the HER2 positive, you want to give the chemo before surgery. In these patients, the reason for that is you have no idea what works for the most part. You know, the chemo is blind. You just know that they're triple negative, but you don't know what chemo they respond to. So you can do, you know, whatever chemo you think is best for them at the big, you know, before surgery, go for surgery, see if it worked or not. And if it worked some, but not all the way, maybe give them something different to finish the job afterwards. Because you're using the thing in the breast as a marker of what's going on outside the breast. Because the thing in the breast is going to come out. That's not the issue. The issue is any rogue cells that escaped, how are they doing? So you can use the thing that is in the breast that you can measure, you can see as a marker of, oh, I'm making progress. It is working on this person's type of breast cancer, as opposed to I have no idea. It's microscopic. I don't know what's working. So that's the situation you're in after surgery because you cannot follow it. So, and then a little bit about immunotherapy, because you may have heard a lot about it, and just to understand how it works, because right now in some breast cancer patients who are triple negative only, we are using immunotherapy. So what is immunotherapy? Immunotherapy is basically getting your immune system to recognize that these cancer cells are foreign and they shouldn't be there and they should be destroyed. So why is it not happening, and how do we help the immune system now do it? So normally, without these drugs, this is what happens. So this is the tumor cell. This is your white blood cell. The tumor cells, because they are abnormal and they are expressing proteins that shouldn't be there, they have these things on their surface, proteins we call antigen, that are abnormal, shouldn't be there. So the immune system does recognize them and says, aha, you shouldn't be there. But before it can attack them and destroy them, the immune system, the tumor cell has a different thing. Has this other thing on its surface. It's called PD-L1. And this is a specific protein. And this protein is sort of like a shield that normal cells are only supposed to have. So when this protein gets recognized by the white blood cell, the white blood cells are, oh, I'm sorry. No, you're actually okay. You're one of us. Nope, I won't. This one I will ignore. You're one of us. I will not attack you. You can think of it that way. So the immune system, even though one part of it says, oh, you're not normal, the other part of it says, oh, you are fine, and doesn't attack the cell. So what these drugs do, these immunotherapy drugs, they go either block this, they bind here, or they block that. They're anti-PD-1 or anti-PD-L1. When this interaction can no longer happen, then the immune system is free to say, yes, you're not one of us. I need to destroy you. Okay, so that is in a nutshell how immunotherapy works. Basically, the drugs are not killing the cancer. It's your immune system that finally is able to recognize the cancer cell. Now, a lot of times it has to be combined with chemo because chemo helps express more of these things on the cell surface. That's the reason it has to be combined with chemo. Although there are some cancers that we have found that there are enough abnormal, not breast, but like lung and melanoma, that they have enough of these things already that we don't have to use chemo. Breast cancer is not one of those, at least not yet. So it has to be combined with chemotherapy. So right now we are doing immunotherapy with chemotherapy for a lot of triple negative breast cancer patients before surgery. And the ones who have metastatic, we've seen that only the tumors that are positive PD-L1, there are tumors that are not. Tumors that have the PD-L1, only those patients we can use the current immunotherapy drugs as we have them. That turns out to be about a third of patients. So for those patients, we use it. So it's critical that obviously your doctor is aware of all of this and is able to add immunotherapy to triple negative breast cancer patients when appropriate. So in conclusion, breast cancer can be curable when it's diagnosed early. And the treatment, of course, involves surgery, but a lot of times also involves chemotherapy, hormonal therapy, and radiation. And you really, really need to ask to see a medical oncologist as well as a surgeon when diagnosed before surgery actually happens. So it's a very multidisciplinary discipline. So you want all your doctors to be on the same page, talking to each other, and making sure that, the thing that is supposed to come first actually happens first, instead of rushing into surgery when the appropriate thing would have been to wait and actually do the chemo first. So that is my didactic. I'm going to stop sharing and open it to questions. So,
Dr.
Yes,
Thank
please
you.
go.
Dr. Peddi, did you want to start with the questions
Yes, that
submitted?
were submitted before.
Yes.
Maybe if you can bring that up, or let me see if I can.
Yes. Let me bring it up one moment.
A few people submitted.
And for those, for the Q&A session, we're going to go with the questions that we have been submitted first, and then we will open up the floor.
And feel free to put them in the chat box, or we can say them verbally too.
Yes.
Okay.
So the questions that have been submitted.
I found them. So I can.
Oh, you did? Okay, perfect.
No worries. You don't have to read them off. So first question was, what progress, if any, is being made towards a vaccine? So it's a great question. So you can think of vaccine two ways. Vaccine for everybody, people who've never had cancer, to prevent them from getting breast cancer. We're nowhere near that. Or vaccine for someone who had breast cancer, whether it's metastatic and is right now in remission, or localized and got surgery, and you don't want them to get that cancer again. So in people who have cancer just localized in the breast and you just have been taking it out, we're not there yet either. There are some, I don't know if you call them vaccine or not, there are some treatments that involve injection of the tumor with inflammatory things that basically promote the immune system to attack the cancer and then do surgery. But I don't think of that as vaccine per se, but that is in clinical trials, in case that's what you were asking about. And then in terms of the best one that I was hoping is that someone who has metastatic cancer, right now they're in remission, some kind of vaccine to keep them in remission for longer. So there have been several of those that have been tried in clinical trials and unfortunately have not worked yet. But clinical trials are ongoing, so we'll see. But we don't have any yet. Is it in the works? And I think first is going to happen the people who are metastatic. We're going to hopefully find something for them first, and then gradually move it up to people who have other options, but the vaccine can hopefully beat those other options. So that's as far as vaccine. So not there yet. Any do you develop for early detection? So I assume you're asking about people who had breast cancer, had surgery, their treatment, whatever that was supposed to be. And now we're thinking they're done, but we want to detect it early if it happens again, if it comes back. So that's usually what I think of when I hear people asking about early detection. So the problem with that is CT scans or PET scans are only going to find stuff are at least a centimeter big or big enough to be seen. So by then, unfortunately, the cancer is already incurable. So it's not early enough. And blood work, so there are things called tumor markers that can be sent on patients, and I generally do them on my patients, but they are not very accurate and can go up and down when there is no cancer. And by themselves shouldn't make someone suddenly start chemo. You have to still find it and really make sure that it's true. So those have those caveats. So the latest now is circulating tumor DNA. So this is now fragments of DNA of the cancer that you try to find in patients' blood. And there's a company that does that, several that are, that are trying to do this, and they have approval in terms of at least the test itself, but is not, for the most part, insurance reimbursed. And we don't know yet how to interpret the results, because if it's positive, okay, do we suddenly put patients on chemo if I can't find something because it's truly positive? And that's number one. And number two, even if it's truly positive, can I do a light chemo because it's early detection, or do I have to do a lot? So those questions have not been answered yet. So it's great when it's negative, but when it's positive, you're still not really sure what to do with that. But that's where we are with early detection. So tests are being developed. Now we're in the next stage of what to do with the results and how to actually change management as a result of those. But great question. Then, and then the last person, it was more specific to them. So I will leave that to the end. And I want to answer more generalized questions first. So Rebecca, do you think we go by the chat box, or did you get something that's different?
Yes, we can do the chat, and for those in person, if you want to ask your question out loud, you can use your raise hand motion. This is on the bottom of your control panel. This is raise hand with the hand, just so I know that you're waiting, so I can call on you when it's your turn. Thank you.
Sounds good. So I'll go through the chat. And again, the ones that are more specific, it may be hard for me to answer completely, but I'll try my best. The first person is like, none of your chemo for HER2 have worked for me. I am sorry. Nothing is perfect. None of these treatments work for everybody. But HER2 positive breast cancers at least has more drugs approved more recently than almost any other types of breast cancer. So, and I think more and better things are going to come along. So I wouldn't give up that, these things are not going to work, but perhaps until like really good newer anti-HER2 drug comes, you need to be on just regular chemotherapy that is supposed to, kill most cancer cells, whether HER2 positive or not. But nothing will work on everybody. For certain populations, mammogram would always show dense. Do you see screening MRI becoming a modality for them? So it's a lot of debate on this and a lot of controversy. Like, okay, you have dense breast. Now it's California law and national law that you have to be notified that you have dense breast. But nobody says now what. So what exactly do I do? So the different organizations are not really quite agreeing what to do if someone has dense breast. So in my practice, what I do, if someone has extremely dense breast, I talk to them about it and put it in perspective in terms of their risk, and recommend at least an ultrasound in addition to mammogram, and sometimes an MRI too, especially if they've had breast cancer already in the past. If they haven't had breast cancer ever, and they don't have a BRCA mutation, and they don't have bad family history, I don't think most people need MRI screening. I think ultrasound in addition would be fine, because we know that MRI can lead to a lot of false positives as well. So that has been the general guideline for those patients. But if they have family history and or the genetic mutation and they have, dense breast, then MRI is recommended in addition to the mammogram for screening. Somebody has tried Nerlynx. Yeah, we didn't talk about Nerlynx. That's neratinib, and there are many other anti-HER2 drugs that I didn't touch base on, and some of them older and in HER2. And if it's working, it's working. You should not change your treatment. But if it doesn't work, whenever it doesn't work, then it's good to know you have lots of other options. When is a PET scan given? Someone is asking. So there are two types of scans one could do to try to figure out if there's cancer outside the breast or not. One is a regular CT scan with IV dye. The other is a PET scan. Is basically a radio-labeled sugar dye that cancer cells that take up sugar more actively than normal blood would light up. For breast cancer, a lot of breast cancers actually are not super active, meaning even if they're out there, maybe they're like so many places even, but they're slow growing. So as a result, PET scan would miss them. PET scan would actually miss these cancers because they're not so active more than the blood that you actually see them clearly. So for these patients, you would do a CT scan would be better. There's a new PET scan actually approved that looks for estrogen positive breast cancer. It's called estradiol PET, or Siriana is the other name for it. So for some patients, I do that specialized PET scan. If I think the CT scan is missing something and I don't think the normal PET is going to show anything. So that's something that is not every center has. So you need to ask whether your center has that or not. And is a newer thing, is specialized estrogen PET. But a regular PET is good for triple negative breast cancer that is super aggressive. But for a majority of breast cancers, a regular CT is actually better than a PET scan. Next question, why immunotherapy only used for triple negative breast cancer? Because the cancer cells have to be enough different from normal that the immune system has to find out. A lot of our estrogen positive breast cancers, yeah, they're cancers, yes, they can spread, but they masquerade as normal enough and that's why they're still dependent on estrogen, that the immune system has a hard time finding them, even with the immunotherapy drugs that we have right now. Maybe in the future, our immunotherapy drugs will be better and can find those cancer cells, even though they're more normal-ish. But right now, we can only do it with our more aggressive ones. What's your opinion of using hormones, bioidentical hormones, 5 years after DCIS? So in general, hormone therapy increases breast cancer risk. because it's estrogen, and majority of breast cancers are estrogen dependent. But if someone has only DCIS, and I didn't touch base a whole lot on DCIS, I don't think at all. DCIS is stage 0 breast cancer, cancer that did not break through the duct wall, did not spread. So for those patients, the risk is much lower. If somebody has had a mastectomy, they have had, not a whole lot of DCIS, and they really need hormones for whatever is postmenopausal symptom that it is, then they could cautiously use a low dose and they'll be fine. But people who've had an invasive breast cancer and that is hormone dependent, I would not recommend that, even if they're years from diagnosis, because it's hard to know if they're completely out of the woods and no cancer cell is there. Is there a new blood test that recognizes cancer? So we talked about that. That's the one that is a circulating DNA, tumor DNA. The name of the company is called Signatera or Natera. That's the main company that does that right now. But like I told you before, it's not always covered by insurance. And more importantly, it's hard to know sometimes what to do with the results. So I wouldn't do it in the middle of treatment. I would only do it when treatment is completely done and with the knowledge that sometimes it can cause anxiety and not in treatment times. What is the minimum size tumor which 3D mammogram can detect? It depends on the location, depends on this dense the breast is. Usually it has to be a few millimeters at least. I would say 5 millimeters or so before you can see it. So it can't be super small. Or if it's associated with calcifications that help you still find it, that's possible too.
Dr. Peddi, we had someone who raised their hand. Sherry, if you're there.
Yes.
Can you unmute yourself and ask? Sherry? Okay, when I see her back, I will ask her for her question. We can just go to the next one in the chat for now.
No problem. And let me see. Now I lost where I wasn't.
Is it safe to take progesterone for uterine hyperplasia if the estrogen more so positive? The one at 138.
Is it safe? Yes. To use progesterone for uterine hyperplasia. I will talk to your gynecologist for this. If it's truly needed, depends on the breast cancer and what you had and how long ago it was and how much is really needed. I would still try to avoid it if possible, but it's lower risk compared to estrogen.
Sherry, are you there?
Yes, I am. Can you hear me now?
Yes, go ahead.
Okay. I have a question for you regarding the Oncotype test. Are there ever circumstances where you decide the test is not necessary? I'll give you an example. A small tumor, 0.9 centimeters, very ER positive, PR positive, but it's grade 2 and KI 57 was 15.
Yes, there are lots of situations when I wouldn't send Oncotype because Oncotype is a test, a company that does the testing, and it could be wrong, could make a mistake. And I don't want that test to determine treatment if your cancer otherwise, everything else point to the fact that you shouldn't get chemo. And then this thing randomly says you should get chemo, and now we're obligated to do this thing that wouldn't make sense otherwise. So for what you mentioned, for example, yeah, it doesn't, and especially if that person is postmenopausal, I wouldn't send Oncotype because it doesn't look like that person is Oncotype. It's a small thing, it's lymph node negative, the KI is not that high. So if Oncotype comes out borderline, it leads to all this anxiety, like, should I do it, should I not? And the test could be, still is a test. Nothing is 100%. So I would put it in the big picture and with everything else that we have and not let one test trump everything else. So I wouldn't send it if for that particular patient it's pretty clear they shouldn't do chemotherapy, is going to cause them more harm than good.
Thank you. You can go back to the chat at 139. What happens if MRI finds a positive?
So then if the radiologist truly thinks that is positive, then you need to biopsy that thing. So typically what happens is we do what's called a second look ultrasound. So that person goes back to ultrasound, and now the radiologist knows what is the area that MRI saw something. And the ultrasound tech tries to see if they see anything there. Now that hindsight 2020, we know exactly where to look. Do we see anything? And sometimes they do. And if they do, then they biopsy that thing through ultrasound, and that's the end of it. But sometimes you can't find it. It's just enhancement on the MRI and there's nothing else. So then you do what's called an MRI guided biopsy if the suspicion is high enough. So you can still biopsy it if you can't see it any other way, but you're suspicious enough to do it. So yeah, same thing. You still do a biopsy, but so-called MRI guidance. Oh, this was Sherry. That was in the chat box as well. It's the same question. Oh, repeat the name of the newer pet. It's called Syriana, and I can put it in the chat box. Forget if it has 2 R's or 1 R, but Syriana, pet, and FES. So that's basically an estradiol pet. So that's the new name of the new pet. Are dense breast tissues hereditary? My 30-year-old daughters need to be concerned about this. So they can be. It can be genetic, dense breast, but a lot of times they're more a function of age. Like as we get older, our breasts naturally become less and less dense, i.e. less glandular. But there are some people that are in their 80s and they still have dense breasts, and that's genetic. And so yes, but I don't think daughters need to be concerned about it per se. I wouldn't start screening as a result. I would base it more on anything else. Like, for example, if a mother was diagnosed at age 40 themselves when they had breast cancer, the recommendation is to start screening 10 years earlier for their daughters. So in that situation, I would. But otherwise, in 30s, patients in their 30s don't necessarily, most of them don't need testing. When do you consider breast cancer cured? If still taking anti-estrogen treatment, is it still considered active treatment? I get asked this question like almost daily, multiple times a day. So am I cured? When am I cured? So what does that mean? When is the step I can tell other people I am a cancer survivor, I'm cured? So I tell patients, right after the surgery, you should consider yourself cured. You should consider yourself cured unless proven otherwise. And you're doing everything else, the anti-hormonal if you're doing, if it's chemo is what you're doing, if it's radiation, everything else that we're doing afterwards that we think makes sense for you, think of it as an insurance policy. Think of it as a way to hopefully make sure that you're cured. But we don't have any evidence that you're not, right? So we can't tell you after the surgery for most patients that you still have cancer left or not. A lot of patients truly are cured with surgery, but for a lot of patients that are not, our other treatments will do the job. But again, we don't have a test yet to tell you when that exactly happens. So that's why I would assume the most likely scenario that you are cured, and see your doctor and do your testing and do the additional things that I recommend based on the odds for your type of breast cancer, but assume that you're cured and live that way because most likely that's the case. So as of surgery, I tell my patients, consider yourself cured. Everything else is insurance. That's how I look at it.
Thank you. Are there any other questions? You can feel free to type it into the chat, or you can unmute yourself and that would be my indication to call on you. I wanted to ask Dr. Peddi if there was any exciting updates that you've learned at the breast cancer symposium that maybe like coming along in the queue that people maybe can think about for the future.
I think one of the most exciting ones is possible approval of this medicine called Kisqali, ribociclib, in patients who are high risk in combination with anti-hormonal therapy. So basically, you had your surgery, you had your chemo, but there were several lymph nodes positive, you have this estrogen positive breast cancer. what else could you do to make sure that this is cured? So right now we have a drug approved for it called Verzenio that I was mentioning earlier. But that medicine can cause diarrhea, can be hard to take. But this other one, Verzenio, doesn't cause diarrhea. It hardly causes many, if any, side effects, and is better tolerated. So that approval may come sometime next year. So that's a medicine that would be new to these high-risk patients with lower side effects. That's one. Number two, attempts at making immunotherapy possible in estrogen-positive breast cancer. So there are several trials ongoing for that. So it will be very exciting to see if we can finally use immunotherapy in those patients. And then use of AI in detection and in mammograms and stuff. So that's another area that is being developed, and we'll see if that's going to help us or lead to more false positives. We don't know yet. So those would be some therapeutics, some detection that we're kind of waiting for.
Wonderful, thank you. Kiana, you have a question? Please unmute yourself. Kiana, you're unmutable, but we can't hear you.
Maybe until she does that. There are two other patients that are in chat box now.
Okay, if you can read those.
Yeah, I'll read those, and then hopefully, Kiana, when you can unmute, please go ahead and speak up. So this person, I have Lynch syndrome, which is a CHEK2 mutation. I have uterine cancer and now going through breast cancer. At what age should my two daughters get genetic testing? So this is very specific. I would have to really know the age of you and when you were diagnosed. And but typically speaking, first, your daughters should, if you were past 50, I would say, then your daughters don't need to be tested now. I think they can wait until they're in their 30s, if they're not yet. But I would probably test them then. One thing about genetic testing is life insurance policies can still discriminate if you have a mutation that is known. So make sure you figure that stuff out before they do this. Like what you're going to do, what implications if they want to do those things. That's one thing to be aware of. But in general, I would wait until they're in their 30s before getting tested, unless you were diagnosed, the patient who asked this, very young, like younger than 40. Otherwise, in their 30s, they can get tested. And if they have this, then they should see like a breast cancer person to get their screening started. Or GYN would be fine too, either way. Then some people need radiation. I didn't talk about radiation. So radiation therapy is basically finishing the job of surgery. So it doesn't help in kidney cancer that's gone outside of the breast, which a lot of times is the most important in terms of survival, but you want the surgery to be complete. You don't want to leave anything behind in that local area. So people who do lumpectomy need radiation most of the time for the surrounding area, because that's the most high risk area. But people who have mastectomy, and that was the question of this person, if they had mastectomy, do they still need radiation? So if the cancer was less than 5 centimeters, it was not that big, and it didn't involve the lymph nodes, then no, you don't need radiation after mastectomy, you're done. Sorry, my battery is low, let me just charge that. But people who have lymph node positive breast cancer, you did the mastectomy, but you left a lot of lymph nodes still in there, right? So a lot of times they get radiation to those other lymph nodes that are still left in the axilla to try to reduce the odds of the cancer coming back. And radiation and chemo are complementary. They don't take the place of each other. So if the cancer burden, that's how the terminology we use, meaning like they had a lot of cancer in the breast / lymph node area, the risk of local recurrence, that area is high. So in addition to chemo, if that person needs it, yes, I would definitely do the radiation too. So they're not interchangeable. Looks like Kiana's microphone is not working. So
You're typing into the chat.
yes. I conducted ovarian cancer research at UCLA, came across some literature in terms of ovarian and breast. We primarily focused on platinum-based treatment resistance. Does platinum resistance play into breast cancer and disease recurrence? So platinum drugs i.e. mostly this drug called carboplatin. E is used mostly for ovarian cancer, not as much in breast cancer, although in triple negative breast cancer, we do use it a lot because those cancers seem to be more responsive to platinum agents. But we don't have as much this resistance business. So like in ovarian cancer, you treat them with the platinum drugs, and if more than 6 months has passed before the cancer has come back again, you can treat again, and they respond again to the platinum drugs. In breast cancer, for the most part, the paradigm has been that if you try the drug and you're past that point and the cancer has come back, you don't retry it again, because usually those cancers are completely resistant to whatever you tried before. So if you've tried platinum drugs in the metastatic setting, you don't try it again. But ovarian cancer is different. They can go into remission again and again if you use these drugs, because they go into treatment holidays, and then the cancer, if it comes back, you can respond again, but not for breast cancer. If metastatic cancer has become undetectable, you're welcome, Kiana. If metastatic cancer has become undetectable, why is it not considered a cure? So someone could have metastatic cancer and they're on treatment, and right now their scan doesn't show anything, doesn't show any cancer anywhere. The reason we don't call them cured is almost always, but I put an asterisk at the almost always, is just quiet at the moment. Once it has spread, once it's outside of the breast, most of these patients, the cancer is just microscopic, and that's why you don't see it on the CT scan, but it's there. And it will become resistant at some point to whatever you're doing at the time. And unfortunately, then you will see it on the CT scan then. But we have reports of some patients that it's years and years and years, and really there's nothing going on. Especially in patients who had cancer gone to like just one spot or two spots, and maybe you did radiation on those spots. Maybe cure is possible in some of those patients, but we don't have a whole lot of data and a lot of studies on that. So we don't know who exactly those patients are. So it would be very tricky to stop treatment. So I wouldn't say, oh, looks like you're cured, okay, let's stop. It would take a really high bar to cross that. So I would tell them, maybe we're lucky, maybe it's correct, but I want to keep you on this treatment, because if you were playing odds, the odds were that the cancer is still there, it's just asleep, and our treatment is working. So let's not rock the boat. Okay, and this may be our last question. Okay, there's one more. Maybe the other one is our last question. So these two I will answer, and then we'll wrap it up. If immunotherapy is eventually developed and approved for hormone receptor positive, can patients who are past active treatment and hormone therapy still get it? We don't know. Depends on the trials that come out. I would say for the most part, it will be on for metastatic patients, not people who finished it a while ago. Now they're all good, and now you start them on immunotherapy, because majority of those patients are truly cured. So I wouldn't just add medicines at that point, because you don't know who needs it, who doesn't. So people who completed treatment and are done, I wouldn't restart anything at this point on them, unless it was a vaccine that was approved exactly for that. And then this person, last question. I'm awaiting my lymph node pathology after double mastectomy last week. One removed lymph node was clear. The other side had atypical cells. What are atypical cells? I'm concerned. So if it's kind of hard to know what they meant by atypical cells. Usually pathologists don't say that. They either say cancer cells or not, but this may be because they couldn't really tell. So if they can't be sure that it's positive, then I would have to talk to the pathologist and figure out the degree of suspicion. If we think could be positive and it was a sizable amount, I may err on the side of caution and treat you as a lymph node positive patient. That doesn't necessarily mean chemo. You still get oncotype and not need chemo if you're postmenopausal. But maybe, doing the anti-hormonal maybe a little bit longer, or at least consider sending the oncotype. So I would do those things, and so I would talk to the pathologist. I would have your doctor talk to the pathologist, really understand the degree of suspicion. And if they're erring on the side that it could be positive, I would treat it as that. I wouldn't say, oh, who knows, let's not. I would always try to err on the safe side, and treat you as if you were lymph node positive, to make sure that you have a high chance of cure it as possible. So hopefully that answered the question.
Wonderful. Thank you so much, Dr. Peddi.
You're so welcome.